Hi, my name is Shaji Kumar. I'm a hematologist at Mayo Clinic in Rochester, Minnesota. The treatment of myeloma has evolved considerably, especially over the past few years with introduction of several new drugs, including new classes of drugs. Even though the upfront therapy of myeloma has become more effective and more patients are getting deep remissions that last longer, myeloma invariably relapses with the current approaches over a varying period of time for different patients. And eventually, myeloma becomes refractory to the available drugs through a combination of factors, including genetic evolution of the myeloma cell itself. This is where the new drug classes becomes important as they offer an opportunity to regain control over the tumor clone. Now, patients increasingly get combinations of proteasome inhibitor and an immunomodulatory drug, and increasingly monoclonal antibodies as part of their initial therapy, or if not in the initial therapy, at the time of this first relapse. So patients who have had one or two prior relapses often are refractory to two or three classes of drugs, including the immunomodulatory drug, the proteasome inhibitors, as well as the monoclonal antibodies. Once patients become refractory to these drugs, and this would include lenalidomide, pomalidomide, often two or more proteasome inhibitors, and one of the new monoclonal antibodies, it can be really challenging to treat these patients for two reasons. One, uh, the, the medications no longer work as well, and two, the patients often have suboptimal bone marrow reserve that might again reduce the tolerance of the medications that we can use. Now, obviously, the best choice for some of these patients might be the clinical trials that are coming up, but majority of the patients will not have access to clinical trials either because they are being seen in a smaller center, or it's difficult for them to travel frequently to a larger center to be enrolled on clinical trials. In that situation, we do have at least a couple of new drugs, new drug classes that we did not have access to a year ago. And these include selinexor, which is an oral drug, which is a new drug class of nuclear transport protein inhibitor, which has been shown to be effective in combination with dexamethasone in patients with myeloma. We know that selinexor, along with dexamethasone, can be effective in about a third of the patients in inducing a partial response, or nearly about 40% of the patients in terms of providing disease stability when they are refractory to three main classes of drugs. Selinexor has also been used in combination with other standard of care drugs, including the proteasome inhibitors like the bortezomib and carfilzomib, as well as the monoclonal antibodies. While these combinations have been shown to be quite effective, it is unclear how effective these combinations would be in patients who have previously been shown to be refractory to one of these combinatorial drugs. In addition, it's also important to note the type of adverse event with selinexor. There are two adverse events or side effects that are worth mentioning. One of them is the gastrointestinal toxicity, particularly nausea. These patients often require drugs to be given prophylactically, one or two drugs to reduce the risk of them getting significant nausea. The other side effect of NOT is thrombocytopenia, and this can be exacerbated by the drug that it is used in combination with, especially when you use proteasome inhibitors. The second drug that would be of benefit for these patients, which is again a new class of drug, is belantamab mafodotin. This is a monoclonal antibody that has a drug conjugated to the monoclonal antibody. In this case, it is the MMAF. We know from the early studies that this monoclonal antibody is quite effective in targeting the myeloma cells because they universally express its target, which is the BCMA or B cell maturation antigen. Belantamab in the phase 2 studies, especially the DREAM2 study that enrolled nearly 100 patients at two different dose levels, have shown that over a third of the patients can respond to the treatment with the monoclonal antibody. And the responses appear to be fairly durable in these patients as well. Now, one of the main side effects with belantamab has been the eye toxicity. Nearly a third of the patients can have symptomatic eye problems with belantamab, and maybe almost 60 to 70% of these patients may have some changes in the cornea that would require cross monitoring. This is something that has been built into the REMS program that accompanies the recent approval of belantamab, which requires an eye exam prior to each dose. The belantamab is given as an IV drug, and it's given once every 4 to 6 weeks, depending on, again, the combinations and the studies that are being done. And in the approval, it's supposed to be once every 3 weeks. Clearly, other combinations of belantamab are ongoing. There is belantamab combination with bortezomib, the results of which has been presented at the EHA meeting this year, and clearly showed that that combination is quite effective in treating relapsed myeloma. Other drugs, other common drugs are also being combined with belantamab, and we would wait and see what those combinations demonstrate. Now, beyond these two, there are clearly traditional chemotherapy drugs that often these patients have not seen because they don't typically form part of the initial lines of therapy. And these include the alkylating agents like bendamustine, melflufen, or cyclophosphamide, all of which the patients may not have previously been exposed to and could have good efficacy in that setting. Now, there are clearly newer drugs that are on the horizon. There is clearly venetoclax that seems to be quite active in patients with translocation level 14 that's going through clinical trials. There's a new alkylating agent, melflufen, which is melphalan, that is more targeted in the way it is made to reach the cancer cells and affect them predominantly. Obviously, the most exciting of the new drugs in the horizon or new therapies on the horizon are the immunotherapies. We have seen very good results with at least 3 different CAR-T products, which are all in advanced clinical trials and hopefully will be in the clinic in the next year. Similarly, we have seen very good results so far with the T-cell engagers or the bispecific antibodies that again enhances the immune response in these patients, and the initial results appear to be quite promising as well. So hopefully in the next year or two, we will have a variety of different immunotherapy approaches available in the clinic for patients who have become refractory to these drug classes. Clearly, the long-term outcome of myeloma, the improvement of the long-term outcome of myeloma would require us to use these different classes of drugs in a judicious fashion. And hopefully, with these new drugs, we can hopefully cure some of these patients so they don't ever reach the point they are triple refractory. Thank you.